Good evening, and welcome to the third session of our End-of-Life Concerns programming. I'm Nancy Lumley, President of Local Council of Women, and I'm glad to welcome you here this evening. Some of you, I think, may have been to all of our sessions, so just kind of recalling, in the first session, we featured a frontline documentary that was entitled Facing Death, which helped us become more aware of the realities that sometimes affect many people beyond the person at the end of his or her life. The documentary, however, emphasized how each one of us has some control over this situation. This means knowing what is possible and then how to take advantage of it. In our second session, we then learned about all of the various types of healthcare directives as we learned who speaks for me when I cannot speak for myself. But we also want our loved ones to realize the ability that they have to make these decisions too. What do these conversations sound like? How do we begin to even have those conversations? This evening we have with us Dr. Jeffrey Allerton, Carol Seidel, John Van Der Zeen, and Sonia Zeller, who are going to share with us how. And I'm going to let each one of them tell a little bit about him or herself, rather than my giving you a great big long resume here. We will begin with Sonia.
Thank you. I'm going to have my colleagues come up here and join me. We can pass the mic, or if you've got a mic on. So this evening, our ultimate goal is to assist you in having a conversation in regards to if one of these days you could no longer speak for yourself, then who could speak for you, or who would you wish to speak for you, and then they would know what your wishes are. That's our ultimate goal as we leave this evening. So I'm Sonia Zeller. I've been an RN for the last 33 years. It's kind of hard to believe and say that. But for 33 years, and I've worked in various locations in different facilities in the southern region. I'm currently the COO, CNO down at IU Health Paoli. I worked in Bloomington as well, and I've been in Indianapolis in the IU Health System. This is a passion of mine, making sure that each one of us have a voice, and not only when we are able to speak for ourselves, but also when we can no longer speak for ourselves. Because being in nursing, I've seen the individual, not only the patient struggling to have the conversation, but also the family struggling to have the conversation, or the patient can no longer speak for themselves, and now someone else is speaking for them. So I'm going to go ahead now and pass the mic.
Sonia, did you say 33 years?
Yes, 33. I'm only 28, though, so I'm not sure how the math is.
Time for you to do the post.
Oh, yeah, okay, all right, we can do that.
Sorry, that might.
Hi there, I'm Carol Seidel. I'm a social worker working right now in our new IU Health Oncology practice. I've been there since September. It's a new position and a new office, and Dr. Allerton's one of our physicians. Really excited to be there. I worked at the hospital doing inpatient social work. I covered oncology and also 2 North, which has a lot of renal dialysis patients. And I was also at hospice, and I did my training as a social worker here, both at hospice and inpatient. So I've had lots of conversations about kind of going forth with treatment or stopping treatment, quality of life, having talked with families about what they're hoping for their loved ones, helped people have the conversations with each other, and also been an advocate for patients to help them be able to articulate their needs to their physician. So I'm really glad to be here tonight.
My name is Jeff Allerton. I'm a hematology oncology physician, and I'm also board certified in hospice and palliative care. I've only been here since November. I've been an oncologist for 23 years. I got about 10 more years before I do the post. But I have been in various practice settings, single specialty groups, multi-specialty groups, private practice, university type settings, and this to me is also a passion. I spend a lot of time with patients, and not only do we try to help patients get better, get well, but at the same time we help them to have the best quality of life possible when it appears that their disease is not responding to therapy. One of the things that I hope you all learn tonight is that these kinds of conversations, need to happen earlier on in a disease course. They need to happen more frequently. And they need to involve not only the patient, but they need to involve the patient's families and friends as well. So I hope you learn a lot, and please ask a lot of questions.
I'm John Vanderzee, Director of Spiritual Care and Chaplaincy for 3 more days. Will be retiring at the end of this week. So this is my, I guess it's not my swan song. You got me hooked in for September. I've been a hospital chaplain now for 36 years, 24 of those years here in Bloomington Hospital, and no, I'm not ready for a post yet. I've been trained in Respecting Choices, which is kind of the premier program in the country, I believe, for training folks to be facilitators in helping people having these conversations. So, and I've been involved in Respecting Choices since the early 90s. So, and I've had a lot of practice, as you might imagine, as a hospital chaplain, working with people who have been diagnosed with a life-limiting disease, and for whom these kind of decisions and conversations are very important. And I've also talked with relatively healthy people who come into my office and say, I just involved in or witnessed a terrible accident, and in which a young person about my age, and this gentleman was 23 years old, was in an accident, had a brain injury, and is now in a persistent vegetative state. And I want to make sure that if that happens to me, my family knows that they can pull the plug if there's no hope. So even for people such as him, who is young and has many years to go, hopefully, these conversations are just as important for young people to have. So thank you for being here, and appreciate having the opportunity to help teach you.
So all of us actually have been trained in Respecting Choices, so we are facilitators, which is good. And our purpose too tonight was to see that there are multiple disciplines within healthcare that can have the conversations. Not everyone is trained to have the conversations. And one thing that you do have in your packet is a brochure, and on the back of the brochure there's a telephone number there. So I just want to emphasize that piece of it, that we're available to have the conversation or to assist you with your loved one, whomever you would like that to occur with. So I wanted to put that out there as an offer. Again, I want to emphasize the fact that a 20-year-old, 18 years and older, can complete these forms. And we're going to talk about the healthcare representative. We're going to talk about a little bit about the living will. There's some other forms that you have in your packet. The packet is really not going to help you through this conversation. and what we're going to, conversations that we're going to have tonight, it's going to help you after you leave. Our goal with this program, too, was for you not to have to spend any money to make your wishes known. So you have documents within your packet that are legal documents, but they do not have to be completed by an attorney. I'm not saying you shouldn't seek assistance if that's what you choose to do, but you have the documents. And they don't need to be notarized or anything like that. We will talk about one form, which is the Indiana Post. It has to be signed by a physician in order for it to be a legal medical order. But the other pieces of paper that you have in there are specific documents. There's also some information in your packet about an advance directive through the Indiana Department of Health. It's a very nice document as well. And then there's a piece of paper in there that I put the landing page on the IU Health Bloomington website. There's a landing page where you can get the electronic version of all of those documents. So that way, easy access if you wanted to type in the information versus handwrite it. So just because of the legibility aspect of that was important too. Because we got to be able to read it. when it comes to us, we got to be able to read it so we can respect your wishes. Okay? All right. We're going to go ahead now. You guys can have a seat. Thank you very much. We're going to go ahead now. The very first part of this program it's a 15-minute video. And I consider it more like an icebreaker. There's 3 specific scenarios on the video. And the video itself's a little bit aged, but the quality of the stories is what we're going for. And there are 3 different stories. And these are real people, and it's their real story. So I'm going to go ahead and play that for you now. About 15 minutes.
My mother has been chronically ill for several years, and within the past 6 months has really, her illness has really gone downhill. She's a diabetic with a severe heart condition, is legally blind. In December, she went into congestive heart failure, but was not coming out as quickly as she had in the past. She then, her condition complicated to the point where her kidneys had failed. Seeing her like that was very hard for me. I had never seen her that ill and that close to death. After the situation had gotten under control, I went home, and that evening I received a call from Dr. Dahlberg stating that your mother's condition is very, very serious. She is dying of kidney failure. I saw her today with the tube down, respirator. I don't know how much more she can take. I phoned my family, and they said, well, she's gone this far, let's go ahead. And I said, that's fine. They've brought her back. We'll do everything we can. So I phoned the doctor back, and I explained this to him. And then his next question to me was, now in this procedure that we're going to be doing, your mother could have another arrest and not make it. What do you want to do? Well, at that point, I thought, what are you, telling me? What decision do I have to make? And he explained it in the terms of what was my mother's quality of life. So as I looked at my mother's life for the past 6 months, I didn't feel quality. I looked at her life of being in and out of the hospital, sitting in a chair throughout the day, not getting out. I couldn't call my brothers and sisters back to say, what should I do? I I chose to say, no, don't do anything for her. I didn't want to keep her alive just for my own personal reasons or for anything else or to make up for things in the past or whatever. I just felt that her quality of life, it was time, and all the suffering that she's had through her health, it was time to let it go. Well, unfortunately, after she got back on her feet and we discussed a living will as to if something else would happen, she didn't like the idea that she was put on a no code, no resuscitation. And she said she wanted to live a little bit longer. And my reaction to that was, Mother, I did what I felt I needed to do. This was something that we did not discuss. I didn't know how you felt. And it was under an emergency situation. You should never have to be put in a position like I was and make the choice of others. Let them make the choice for themselves. That way, if the choice they make is something they will have to contend with, and no one else will have to.
Life is full of choices. We choose our friends. We choose our careers. We choose whom we marry. We choose what we do with our lives. Just as these are many of life's choices, so are the choices facing us about our future health care. One of these important choices you should make is how healthcare decisions would be made should you not be able to make these decisions for yourself. That's what advanced care planning is all about. Advanced care planning is a process of understanding what future choices you may face, reflecting on what you want, discussing your choices with those closest to you, and formulating a plan. The plan you make is called an advance directive. You may have said things like, I'd rather die than be hooked up to some machines keeping me alive. Or, I don't want any heroics. Well, these are understandable requests. These statements may be too vague, or may not be heard by the people who will make your medical decisions. You need to consider the option of a written advance directive. While written advance directives have many names, there are two common types. One type provides only written instructions about what to do if you are hopelessly ill or injured. This type of document is often called a living will. Another type of document appoints another person to make healthcare decisions for you if you cannot make medical decisions for yourself. This second type of document is often called a power of attorney for healthcare. This second type of document may also include instructions for the person you have appointed. But before putting your choices in writing, it is most important to understand the choices you can make and talk about these choices with those closest to you. Talking with a loved one about these issues may not be easy. Even if it is easy for you, it may not be easy for others. There may be resistance. There may be denial. Many people are uncomfortable discussing anything to do with how they might live at the end of life.
There's a difference of age, experience, lifestyle among myself and my brother and two sisters. They have different interests, they have different attitudes about life, they have, in a sense, in some ways, different values even. And we come from the same household. The common thread that brings you together is family. Well, about 3.5, 4 years ago, my mom was diagnosed with TIAs, kind of mini strokes, in the sense that aren't strokes, but set up, I guess, a real stroke to happen. They're blackouts, kind of blood vessels, I guess, popping. Took me the better part of 2.5, 3 years to get up the guts, so to speak, to say, Mom, let's talk about you dying. It was hard. It was not an easy thing to do. Well, then I began to push the issue of advance directives and living will, and found that my mom nor any of my siblings, my two sisters or brother, were real interested in talking about it. I guess I could use the word denial. It was, nothing's wrong. What are you doing this? I was called insensitive and uncaring, and a lot of name-calling went on, to a point that I felt before Christmas of this past Christmas that I might not speak to my brother or at least one of my sisters ever again. I mean, it was really very ugly. But I guess my mom and my dad both taught us well that you never give up on people that you love. And the door is opened again, and we've begun to talk a bit more. I mean, everyone. Still not easy. My wife and I both considered and talked about this and are in the process of completing advanced directives for ourselves. I don't want my kids to be burdened with me. And more importantly for myself, I don't want to be kept alive just to be kept alive. I owe my children more than that. And more importantly, I owe myself more than that. I've lived a full life. I continue to live a full life. I plan on living a longer and even fuller life, but should something happen that's going to stop that, I don't want to just exist. I want to live it.
These issues may be difficult to talk about, but they still must be discussed with those closest to you. It may be up to you to begin the conversation. It's an important first step of the process. Having these choices spelled out in advance gives you the peace of mind, and even more importantly, you won't be placing the burden of making such difficult decisions on those closest to you. There are many possible situations where advanced care planning would be useful. In making these plans, you need to consider your current medical condition, your own goals and values, and your views about how you want to live your life. Imagine you're in a tragic car accident. You are rushed to the hospital and end up in the intensive care unit. You're unconscious. You have significant brain damage. Doctors agree you may survive, but you will not recover the ability to interact with others. Your heart and other organs could be maintained for long periods of time, for years or even decades. But choices would need to be made to either continue medical support to keep you alive or to stop medical support and allow death to come. You won't be able to make a decision for yourself. Someone would have to make this decision for you. Your doctor and your loved ones would be forced to choose. Or imagine living in a nursing home because you're no longer able to make your own decisions. You have Alzheimer's disease and don't know who you or your family members are. And your condition will only get worse over time. What healthcare decisions would you like your loved ones to make for you? The issues facing us at the end of life are stressful and emotionally draining.
My husband was diagnosed as having Alzheimer's in 1983. He has gone from that to a nursing home. Just recently, I've been told that he has a month to a month and a half left to live. Some days are bad, and then again, they're all right. It's very hard to accept at times. We've been married for 40 years, and I would say that most of those years he has always expressed the fact that he never wanted to ever be kept alive on a respirator or with a feeding tube. He wanted the dignity of just simply dying. I discussed this with our children, and they said, well, Mom, you know Dad's feelings. And I said, yes. And they go along with that. I have talked to his family, his brothers and his sisters, and they agree too. Because the quality of his life is not there anymore. It simply isn't there. The thing that I really feel strongly about is one's dignity. I myself have seen it where they have no dignity left at times. I don't know if you've ever been into the ICU room, part of the hospital, or and right now, my husband is about in that same spot where he's lies in bed in a fetal position, doesn't know me. And I'm sure if he could say today is it, it would be it. But he doesn't have that choice. He just has to wait. And I will not prolong that.
Making choices, understanding what choices might be faced, reflecting on these choices, and discussing them with those closest to you, your doctor, other health professionals, or trusted advisors. In this process, consider the following issues. What would be your goals for your medical care if you could not make your own decisions, and there was no reasonable expectation for you to regain your ability to know who you were, where you were, or who you were with? Would your goal be to sustain your life with medical interventions offered by your doctor? Or would your goal be to make sure that you were kept comfortable and be provided the highest level of function possible? Who would tell your doctor what you wanted? As you begin to think these things through, there are many people who may be able to help you. You may start with your physician or another health professional, with your attorney or a religious advisor. Remember, you can decide in advance how you want healthcare decisions to be carried out. The first step is understanding the choices, thinking about what you want, and talking with those closest to you and your doctor. In the end, it's up to you to make your views known, to discuss the issues, and to make your choices, so your loved ones won't have to choose for you.
Okay, so you can either feel like you're empowered and you can make your decisions, or you can feel pretty kind of solemn in regards to how those decisions. So every one of us are going to have a different feeling and reaction to that video. I see it as, my view is that these individuals have the ability, or they're empowered to make these advanced decisions about their health care that they choose. Because I don't know if I'm going to go out here today and get hit by a car on my way home or not, but I know who's going to make those decisions for me. Yes, I have the paperwork, and he knows what I want, so he can be my voice. That is a difficult position to be placed in, and that person in the state of Indiana is called a healthcare representative. I know on the video it talked about a power of attorney for healthcare. That also is a form too, just to let you know that. But here in the state of Indiana, it's a healthcare representative, and you do have that in your packet as well. So what we're going to do at this point is we have 4 scenarios that we are going to play out for you. And John is going to be the dad. Carol is going to be the daughter. Dr. Allerton's going to be Dr. Allerton. And I am going to be the facilitator in one of the scenarios. Or the role plays. So what we're going to do is, the very first role play, I'm going to have Carol and John go ahead and go up on stage. And they're going to role play a conversation between a father and a daughter. And then we'll have questions and answers. And then we'll have the second role play, question and answers, and so on, until we finish the 4th role play. So as we go along, that way you're able to answer or ask those questions and we can answer them. Okay? Everybody good? All right. Are you two ready?
I think so. Hey, Dad.
Yeah, Carol. It was a great meal, wasn't it? Your mom made? Boy, am I stuffed. That was good, though.
It was good.
So glad you could be here for dinner.
Yeah, it's been really nice coming back and seeing you guys. And, I only get back a couple times a year. Mm-hmm. But I really, really treasure the time that I get to spend with you and see you.
Well, feelings mutual, Carol.
we spend a lot of time too on the phone. We check in every week with each other, and that also, it shows me how much you love me, and I feel so supported by you.
Good.
And Mom, and I always have. And thank you so much for being such great parents.
You're welcome. You're welcome. We're so happy with how you turned out.
Thanks. I want to talk about something that it makes me a little uncomfortable to bring it up.
Okay.
But I feel like it's really important. So even though it may be a difficult conversation, I still want to have it with you.
Okay.
Is that okay? Looks like it's
Yeah.
okay. Okay. Well, since I'm not here as much, I worry about if something happened to you or Mom, who would be able to, be at the hospital or be with the doctors or to kind of tell people what to do, because your families, they're not here.
Carol, I'm fine. I really am. I'm fine.
Well, I know you're fine, and I know Mom's real healthy. I mean, gosh, you guys play golf 3 times a week. You play tennis.
That's right.
You
That's
travel
right.
like crazy.
It's in the genes.
I know, but what if you were on the golf course and something happened? Lightning struck.
Okay.
What happens if you guys, you're tooling out to Arizona and you're in a car accident?
Yeah, it could
And
happen.
there-
Anything can happen.
There you are, and there's nobody.
You're really serious about this, aren't you?
I am. I want to take care of you as well as you've taken care of me. I want to be there for you if I need to be.
Okay, well, let's go ahead. What is it you have in mind?
Well, I need to know more about you, how you would want to be taken care of if something happened.
Well, I would, want the best that can be offered, I guess, Life's pretty precious for me, and I want to live as long as I can. Well, under certain conditions, I guess.
So I know I think about you. When I think about you, I think about you doing all those things like playing golf and tennis and doing all those things. What do you think?
What if I couldn't do those things?
Yeah. What if you couldn't do those things?
Well, yeah, I must admit I had thought about that. It's important for me to live as full a life as possible. There's a certain amount of disability that I could probably cope with. If I had a leg cut off or something and needed a prosthesis, I could probably live with that. My golf game probably wouldn't be so good, but I could handle a certain amount of disability. But you remember what happened to my brother Frank, Uncle Frank, your Uncle Frank?
Yeah.
And he was in an intensive care unit for a long time, and he was on feeding tubes, and I felt so bad for Eunice. She had to make some tough decisions, and she didn't know what really Frank wanted. So, yeah, come to think of it, I think this might be a good thing to talk about, because I wouldn't want to put you and Mom through what Eunice went through. So what do we do?
I think we can call the hospital and ask to speak with one of their facilitators. Shall we do that?
Sure.
Okay.
Okay, good job. Everybody give them a round of applause. That was really good. All right, good job, guys. The one thing that I know that Carol opened up with, and I've used this myself in a professional life as well as personal, is this is difficult for me. If you open up a conversation by saying, this is difficult for me, it's amazing the attention that you receive from the other person. You know, this is difficult. I need to have this conversation, or I would like to have this conversation. This is hard for me to have this conversation. And you opened up with that. And he, you know, John or Dad paid a little bit more attention, a little bit. He finally put the newspaper down. But you'll find, too, that some people keep the newspaper up, and it's easier to have the conversation with the newspaper up. So thoughts as you guys played that out, too, what you tried to do?
Yeah, I tried to be kind of the macho kind of guy, but I didn't want to be totally insensitive.
Mm-hmm. Right.
After all, it's a new age, you know. And I knew how serious Carol was, mm-hmm. and you know, she began to get a little emotional, and Dad doesn't like it when their daughter gets emotional, mm-hmm. and so I paid more attention.
Yeah. Okay. Good. All right, I'm going to open it up to questions, and I'm going to run around with the mic if you have a question, so that way we can make sure everyone can hear. Questions about that scenario, or something that you're thinking about that you could possibly get into that you would want to know how to handle? Okay, hold on just a second. Let me go back here. I'll be right back.
Sometimes it's the older person who wants to start the conversation, and the younger people don't want to talk about it.
Okay.
Yeah, good point. Yeah.
Let's field that
I
one.
was going to say, we actually discussed, like, how should we do the conversation? Should we do it this way, or should we do it with him trying to get me in? Because John and I have both experienced that, where one side wants one and one doesn't. And we just kind of went with this to kind of keep continuity with the next step. But you're absolutely right. Sometimes kids don't want to have that conversation. And I think it's that approaching it that same way. This is a difficult conversation, but it's an important conversation for me. Are you willing to listen to why I want to have it? I want to have it because I care for you, and I know you care for me. I think can really help.
And you know how I brought in my brother, Frank? That was
Mm-hmm. That's right.
Almost everybody has a story to share about a bad experience of somebody being critically ill or dying. Whether it's a friend or a relative, almost everybody can point to a situation that they can say, I don't want to let that happen to me. So that probably should be your, have kind of a situation in mind that you can refer to and say, you remember what happened to so-and-so? That always kind of helps get someone's attention.
Yeah. So 2 things we've learned is, I'd like to have, this is difficult for me. I'd like to have, this could be a difficult conversation, but I want to have it. The second one is have a story. And whatever that story or scenario as an example. So then that way that will help you.
It may be somebody that had a good death.
Mm-hmm.
It may be,
Yeah.
That went, I know it was hard to lose this person, but, everybody was there. It was a loving, environment. Everything went really well.
Their decisions
right.
were respected.
Exactly. So sometimes it can even have been a really positive experience that people draw on to kind of have these conversations or think about how things are going to go.
Yeah, good point.
In the hospital, frequently when I have families who are trying to struggle to figure out what to do with a family member who has not articulated their needs before and they haven't had these conversations, seems like we're all of the generation pretty much that remembers the whole Terry Schiavo case. So I'll harken back to that and say, when, did your mom or dad ever talk about Terry Schiavo when that was going on? What did they know? So I think you can always find something to pull in like that.
Does that help you? Okay. All right. Got another question?
If you have a sister that lives in California and doesn't visit very often, you still go ahead and have the conversation without her?
Good question. I would say, talking about in this scenario, if I had a sister that...
She has a sister.
I see what you're saying. Good question. I think it's still appropriate. It probably would have been a good idea for Carol to phone her sister and say, hey, I'm going to have this conversation with Dad. What do you think? What do you think his reaction will be? Or, what do you think, how should I approach this? So, I think it would be a good idea for Carol to bring in her sister.
Yeah, and I've done that. I've done that with my brother, for both of my parents. And my brother and I have a good relationship, which sometimes families do not, so it makes it more difficult. But he and I communicate really well. I mean, it's by phone because we live in different states. And that was prior to my dad's passing, as caring for him. And now we're caring for my mother at home. So it's that conversation and getting together. And one of us, and what's interesting is we each have our own strengths and our own weaknesses. And we, if Carol's able to have the conversation with Dad, like she did, but maybe the sister doesn't want anything to do with it. And usually one sibling will take themselves out of the situation. They'll self-elect out and say, I don't want to do that. You're fine. You go ahead. You do that. I'm the healthcare worker and my brother's an engineer. And he says, you tell me what to do and I'll do it, but I have no clue what to do. But then there are things that he does and has done for our parents that he's closer than I am that he can do. So it's kind of a give and take. But having that conversation, it is good to be inclusive, though. It's a great question, because if Carol only talked to Dad and her sister had no clue what was going on, she's going to feel left out. So it is good, maybe Carol and her dad go, and talk to a facilitator, which we're going to do that here in just a second. But then we need to make sure we're inclusive with other family members. So it's not a surprise when a crisis does occur, and then you're not only dealing with the crisis, but then you're dealing with hurt feelings, or how did you get elected to be that healthcare rep? When did that happen? So then you're dealing with another situation. So great question.
Now, will these forms, if we fill them all out, would they be complete enough for us to maybe get my family together and say, here, I have here, will they be complete enough? Yes. And just say, I have them all filled out, this is my wishes.
Yes, those forms each form is for each individual. That's the easy way. You complete it and you just call a family meeting and you say, these are my wishes. And then, and whoever's going to be your healthcare rep, you need to identify who that is. And if you can do that prior to that, that's good. But some of the siblings, I know Jan that was supposed to be here with us this evening when she was ill, and her children basically said, I'm not it. I can't do it. So they self-selected out, and that happens quite a bit. And then there are certain children that just kind of say that's just their natural gift to be your voice. And maybe they live closer or they're more like you. I mean, it's just every family's a little bit different.
When you have that conversation with your family, it would be probably a good idea that in addition to the statutory documents, the legal documents, living will, and the appointment of healthcare representative, there's also a form in there called additional instructions. Is that in there? Okay.
No, I don't have that, but you can write anything you want on that.
There's a sheet called additional instructions that you can write, or you can put down more specifically what you would want in a certain situation, right, including organ and tissue donation, or your faith leader, if his name and phone number, all kinds of stuff you can put in there.
Right. Because some of the forms that you have in the package you'll want to complete, and some will be pertinent to you and your wishes, and some will not. Okay, so each of those forms will have to be picked out. Okay, I'm going to move. We got one more question, and then we're going to move to our next scenario.
This is more a comment on the scenario, but since the dad is still in good health and everything, and young people think they're invincible, it might be a good opportunity for the dad to say, well, could we talk about you too? Because parents, it's hard for parents then to make a decision about a child who has been tragically injured some way and are in that end-of-life situation.
Absolutely.
Absolutely. Great. That's very good. Thank you, Nancy. Yes. Because he could have turned it on Carol and said, Carol, do you have yours completed?
I find in the oncology practice, when I address advanced care planning with my patients, that frequently the spouse wants to do it as well. And I definitely encourage it, because I say, I do this with all my patients. It's not because you're an oncology patient or a hematology patient. I address it with all my patients, but it's cool how often the spouse will say, well, I should have mine done too. Can we do them as well? And, yep, let's get them done. Mm-hmm. So that's a good comment, though.
So the goal would be actually that we normalize this process, that it becomes a normal conversation. Actually, in La Crosse, Wisconsin, where we were trained through the Respecting Choices, that's normal. It was like 96% of their population has a healthcare representative on file. They know who they are. And that is really nice when somebody comes to the emergency department in a crisis or a situation when someone can no longer speak for themselves, then they have that ability to say, you know, this is my wife or whomever, and that person's speaking for me. Okay? All right, we're going to move on to the next scenario. So the next scenario is that John's going to come in, and John and Carol are going to come in, and I'm the facilitator. So when you asked for a facilitator, there's some questions that we will move you through a specific process that is evidence-based, research-based, that assist in you understanding what you want. And it takes several conversations to kind of move through this process, to think this through. You know, what are your beliefs? What are your values? What are your goals? It takes a little while to understand that, because in scenario number 3 and 4, there is a reason why we split those up. And that is because when we get to those scenarios, there's more information to think about, and you need time to process that information. Okay, we're going to move on to scenario number 2.
Okay. How do you do?
Hello. Hi, I'm Sonia.
John.
Hi, John.
Hi, I'm Carol.
Hi, Carol.
Nice to meet you.
Nice to meet you. Have a seat. So
Thank
I'm
you.
Sonia, and I'm going to be your facilitator today.
Okay.
And I know you made an appointment to come in and talk.
Yeah, Carol dragged me in here.
She drug you in
Yeah,
here.
no,
Oh, okay.
just kidding.
All right. Well, you don't look like you have much dirt on you, so she didn't drag too much. But all right. So I have got a form here that I'm going to follow that just kind of helps me keep our conversation organized, because I want to make sure that by the time we leave today that I've answered your questions, and that you have an understanding of making sure that we respect your wishes. Okay?
Great.
And so I'm going to go ahead and just start asking just a few questions, just kind of get a little bit of a feel for, tell me a little bit about you coming here and what your goals are for today, coming to having these conversations.
Well, this was something I really wasn't thinking much about until Carol brought it up after dinner last week, and I must admit it kind of caught me by surprise. I wasn't expecting her to be talking about my dying or my getting sick, because I'm fine. But then as I noticed how serious she was about it, and I recognized when I remembered my brother and his illness and how he died slowly, I thought those conversations didn't happen with my brother Frank, and look what happened. So I thought maybe it is a good idea to sit down with somebody.
So yeah, as a facilitator, I can help you with that. And okay, so you talked. So Carol's your daughter, and you talked about the scenario where you had your family member.
Mm-hmm.
So of that situation, so tell me a little bit about that situation. What concerns you had about that, or fears, or so that way Carol can understand your feelings about that situation.
Okay. Well, he had a massive stroke, and Frank has never really been that well. There is a history of vascular disease in our family. So far, fortunately, I've been spared that. But Frank had a pretty significant stroke, and it left him paralyzed and couldn't speak, couldn't swallow. Finally, they had to put down a feeding tube and things got worse, and he was in intensive care for, gosh, it must have been 3.5, 4 weeks. And it finally got to the point where the doctors talked with my sister-in-law Eunice and the rest of the family about, how much further they want to go, and they were dumbfounded. They didn't. Frank didn't. He was not one to talk much about his feelings, and kind of kept to himself. And anyway, they were in a situation where they hadn't a clue what Frank would want, so they had to make these decisions without knowing, without having any kind of conversations.
So your sister-in-law she was making those decisions.
Yeah,
and it was
since she was the closest relative.
Okay.
Yeah.
So thinking about that situation, who would you want to make those decisions for you? If you could no longer make decisions for yourself, who would you like to do that for you?
Well, there's you, and then there's Kate, and Mom, of course. I don't know. Mom and I, your mom and I are, obviously, we've been married for 30 years. We're very close, but she's kind of cloying sometimes, She's so I'm not sure if she could handle that decision, those kind of decisions. I'm afraid she would,
And that's fine. And we don't have to make that decision today. This is part of having the conversation, so that way we can get to the point where we can respect those choices.
What should I look for in choosing a healthcare representative?
I would suggest at this point having conversations with your family and seeing if, who would be that person. Someone may say, I can do that for you. Your wife may say, if we get into that situation, honey, I just really don't think I could even make that decision. But yet maybe Carol, Carol's here with you today. She's the one that approached you. And you said Kate,
That's
but
true.
Does Kate live here closer?
Kate's in California.
Okay. So
Yeah.
Kate's in California. Okay. So, and Carol's here closer, which
I think I'm the more practical one in the family, and I think I'm the more planner one.
Yeah,
but
Kate's more like her mom, kind of an emotional and.
I'm nervous about taking on a role like that because I don't understand what kind of decisions I might have to make. So that's the part that would worry me is I don't understand why you would need a feeding tube or when it would be a right time to have a feeding tube or maybe a wrong time for Dad, and so those are things that would really kind of intimidate me about being in that role. I don't really understand a lot of that.
Yeah, none of us have a healthcare background, so.
Okay. So the things that we're talking about today first is we need to identify, or for you to identify, who would be that person that could speak for you when you no longer could speak for yourself. That's the first thing, is thinking about that, processing that, and talking with your family, okay? Mm-hmm. And then you brought up some of the other issues like feeding tubes. We talk about, issues if, for example, if your heart stopped or you could no longer breathe on your own. These are starting the decisions that need to be made. If your heart stopped, would you want us to start it again, or attempt to start it?
Sure.
Okay. So in a breathing tube, if you ever seen anyone with a breathing tube, did you say your brother, he couldn't speak for himself? Frank, he had a breathing tube.
Ventilator.
Yeah, and they did a tracheostomy or something like that.
Would you want it to have that tube and then have the tracheostomy and being on a ventilator? I'm giving you a lot of things to think about today. Right. And I don't expect you to make decisions today. I'm just kind of bringing that up. So we talked about the healthcare rep. We've talked about, would you want a tube and be on a ventilator? And then feeding tubes. Those usually don't start, right at the beginning if you're on a ventilator or after you're tubed. It could take a little while to make that decision. So it's not like a decision you have to make right away, but it could be a potential. So it's something else to think about, is what it is.
What would be the reason for a relatively healthy person like me to be choosing someone like this? I don't anticipate, we have some vascular disease in our family, but I exercise and play a lot of golf. And
actually, this is the best time to do it, because then you then can think about what your choices are that you would want. What if you got hit by a car, and you no longer could speak for yourself? 3 o'clock this afternoon, all of a sudden you could no longer speak for yourself. And having someone appointed to have that conversation.
Remember George, and that happened to him. He was in the perfect health, and he had was going under an overpass, and somebody dropped a stone or something through his windshield, and poof, there he.
That was it.
Yeah. I mean, we never know when that's going to happen. So I think, anyone having the ability to already have that appointed person, it's really a gift is what it is. Because if you, let's say it's 3 months from now and you've had the conversations in your family and Carol is your healthcare rep and she knows exactly, then that's really a gift that you could give your family. And because it's very difficult to make those decisions when you're in a crisis situation. There's a lot of emotion and the unknown. So, okay. All right, we're going to end this scenario at this point. Okay, so what we tried to do was demonstrate a little bit about the conversation and about the choices that as you have these conversations that you're going to need to make. And they're not easy decisions. And it takes a little bit to process that information. So questions in regards to this scenario? Thoughts?
Am I correct in understanding that if we don't name a healthcare rep in the state of Indiana, that the person's spouse, children, and siblings all have equal say?
That's correct.
Because the state doesn't recognize a hierarchy?
That's correct.
So in my personal case, that's 3 people. Okay, but if you have 10 people, they all have to agree. Okay.
Unless you appoint a healthcare rep.
Yeah, and that's exactly what happened years ago with my grandmother. My dad had 8 brothers and sisters, and they could not agree. And I look back on that now. That's part of it happened for a reason, but I distinctly remember that. And there were things in way I would want was not the way she was cared for. So yeah, very important to have that information and to have that document so it's readily available. Okay, good question. Thank you. Any other questions?
I could have, part of this conversation would, if I was a really practical man, which I am, I could have said, okay, I think I know what I want. Let's appoint a Carol. Let's get this thing rolling. And
right.
I would have asked Sonia to draw up the papers.
Right. Yeah. So. And we could have. I mean, you could come in knowing exactly what you want. You've gone through, your paperwork and come in. But you may also be asked some questions that maybe you don't know the answer to, that you might need to leave and go home and process it. And that's perfectly okay. You can walk in and say, this is exactly what I want to do, or I just want to have the conversation, or something be brought up. The other thing that we didn't go through in the scenario is explore religious, cultural, and personal beliefs. Making sure that we do that as well. Some individuals like to go back and speak with their clergy or a rabbi, whomever, whatever their beliefs are, just to make sure that they're in line with the way in which they believe. And then what I would have done is I would have ended it with a follow-up. Either made another appointment with them, or to go because they do need to talk to Kate and they need to talk to Mom, because they need to know and be part of those conversations. Go ahead.
If you appoint somebody who's not a family member, can the family members object?
No.
No, the healthcare representative would override that.
Once you appoint a healthcare rep, that's the buck stops there.
One thing I was not clear. Now, you were the facilitator, but for whom? Were you an attorney or the hospital, or who?
So I'm an RN, but I have training to facilitate these conversations. So does John, Dr. Allerton, and Carol. So, right. They did. And the telephone number's on the back of that brochure. I'll hold it up here. I'll be Vanna for a minute. Okay, so you've got a brochure in your packet. And on the back of it at the top, telephone number is 353-9191. And you can call that call that phone number, and we can have. It is. Yes. I mean, we can meet at McAllister's if you want to come meet with me or something. We can meet wherever you want. But yeah, I mean, we can figure that out. Is what we can do. Okay.
Facilitator's job is really only to draw stuff.
Correct.
They're not really working for someone in particular, not John Carroll, to help them look at the issues and enable them to make these decisions.
What happens if you've made a decision as to who you'd like your health care representative to be, and then later on you want to change your mind?
All you have to do is rip that piece of paper up and fill out another one. And the papers that we have in the packets too, just to let you know, is you own those papers. Those are yours. But what you can speak, those papers only speak for you when you can no longer speak for yourself. So right now, if you're sitting here or talking to me, and I'm asking, I'm your nurse, how do you want to be cared for, whatever's going on, you're going to tell me. But then at some point, if you were to lose the ability to make those decisions for yourself, then that's when the paperwork kicks in. And any of this paperwork can be ripped up at any time. At some one moment, you can be telling me that your husband is your health care rep, and that's your paperwork, and it could be yours. You could rip it up and then make it your daughter or whomever. So these are documents that you own. Okay, thank you. Let me go back here. I'll be right back. Okay, so her question was, how do those papers become legal? Each one of the documents that you have in your packet are legal documents, and they can be completed by you. Some of them require witnesses. None of them require a notary. There's an Indiana Post that we're going to get to here in just a few minutes, and it has to be signed by a physician in order for it to be a legal document, a medical order.
But the living will and the appointment of health care representative has to be signed and witnessed, and that makes it legal. Simple as that.
The witness, though, can't be a family member or anybody
Right.
that would benefit from your death. So, and then within the hospital system too, because I encourage my patients to have their advanced care directives put into the medical record, so that if they ever come in, they're both in the Southern Indiana physician as well as here at the hospital. And if you do a new health care rep, that goes into the record, and we always look at the one with the most recent date. That's the one we check. So I've had people who I've looked, and they'll have 8 different advanced care directives in, but we go to the last one, and then I always ask the patient, I noticed that you have a health care rep or a living will. It says this. Is that still your wishes? So it's not like we've done this once and there's no way that we can change our minds. You definitely, and you should be thinking about that always. Is this still what I want?
Right. Every couple of years, kind of like your financial. Yeah. I mean, the advanced directive or advanced care planning is like advanced financial planning. Problem is I don't think we think about our health care planning like we do our financial planning.
Good point.
Okay. One more question.
My understanding is, at least in the state of Indiana, that you can make your wishes known in a living will. I don't want to be resuscitated, but my children could come in if I am unable to speak for myself and change that. That is not necessarily binding. If I were unable to speak for myself and my kids, say, wanted to do something different. Is that true or not?
Our attorney has advised us that a living will trumps a health care representative. So whatever you state on your living will becomes the number one thing.
So
we had a case like that a couple of weeks ago, where a person had appointed a health care representative. Health care representative wanted to do everything possible, but the living will said very clearly, in fact, there was even a handwritten thing on the bottom, it's explicitly saying, if don't keep me alive if I'm in a hopeless situation. The living will basically is what the ethics committee decided to go by.
Okay. All right.
There's a question back there. He's been.
There is no spouse and there is no children, who would you want your health care information released to? Because with privacy, unless they're in that order of precedence, then the hospital is just not allowed to release information. So for those without a spouse or siblings in the area, who would you designate that you'd want health care information access to your condition?
So, Carol, you had that scenario last week or something like that, or within recent, that you had an individual that had no one to speak for them, and it was a very difficult situation.
Yeah, I've had several of those that have been really difficult trying to track down.
When we find those situations in the hospital, and if the patient has decision-making capacity, that our number one priority, in addition to his health situation, but our number one social priority is to encourage him or her to appoint a healthcare representative. And that could be a neighbor, could be a faith leader, could be anyone he chooses, or she.
Okay.
I guess a clarification. Is it automatic that if you've been named healthcare representative, you will have access to medical records of that person, or does that person does that name have to show up on a form saying these are the people that can have access to my healthcare record? Do you see what I'm saying?
Yeah, I think the healthcare representative won't need additional paper or instructions to get the medical record. That will not.
Good question, but we're not attorneys, so I need to say that as a disclaimer. We'll need to ask Jim, and we can get the answer to that one. If I can get your email or contact, and I can get back with you with that information. I don't want to. Right.
I'm the only person, but there's nothing legally. My name's the same.
Right.
But they were so concerned about the privacy.
Right.
And here we were just concerned about.
Yeah.
I didn't even see my dad.
Yeah.
So
Yeah.
having a healthcare representative, who I am, would in fact allow me to.
Right.
Correct.
Yeah.
Right. Right. Right.
Exactly.
Yeah. And that's vitally important. It is.
Time for the next scenario.
Okay, next scenario, so we can keep us going here. Okay, so I'm going to introduce Dr. Allerton's going to come up now. Okay, so John has been diagnosed with lung cancer, unfortunately. Okay, so John and Carol have now come in, and they're speaking with Dr. Allerton. Again, we're going to have two scenarios because it's vitally important to know that it's difficult to have a diagnosis and to be chronically ill, and then to have these conversations and the decisions that need to be made. So we want to make it a little, and it could be 3, 4, 5, 6 conversations with Dr. Allerton, not necessarily 1 or 2 that we're going to have here.
Hello, John. I'm Dr. Allerton. How are you, sir?
Dr. Allerton, what you doing with that microphone?
It's a new instrument that I'm going to use today.
I'm John's daughter, Carol.
Hi, Carol. How are you?
Good, thanks.
John, is your wife here today?
No, she's not. She is not well, and plus, this would upset her so much. And Carol is my healthcare representative, and I think it was most important that she be here.
Okay. Are there any other family members?
Yeah, we have another daughter, Kate, in California, and she knows what's going on.
Okay, good.
Yeah.
The reason why I asked that is because I want to make sure that everybody's on the same page. Yeah. Okay. Tell me why you're here today. I obviously know why you're here today, but I want to hear from you what your understanding is.
Well, you told me that I have you found this nodule on my lung, and which surprised the hell out of me because I've never smoked a day in my life. And I don't know how anybody can get lung cancer without, I mean, I can think of some jobs I worked at which had some kind of hazardous material, but anyway, it was a totally out of the blue, Doc. We talked not too long ago about these kind of conversations might happen someday, and I just wasn't prepared. So I want to make sure that my family knows precisely what I want if things should go sour.
Okay. Carol, what are your feelings?
Well, I'm really worried about my dad. I mean, I'm really scared right now, and I want to know what we're going to do and how it's going to look for him, and is he going to be able to do the things that he likes to do, or what is this all going to kind of be like? And I'm worried too because I'm here representing the family, and I'll have to go back and talk to the family, and I feel a little stressed about doing all that, but I also,
it's a big responsibility. I feel bad for Carol having. I mean, I know she can handle it, but it's just a lot to put on her shoulders.
And I'll be able to handle it, but I just really want to hear what's going to happen with Dad and how things are going to be. What can I expect? What can he expect?
Well, let's go over a couple of things. First off, I want to say that there's two broad categories of lung cancer, and when they went inside and took that biopsy, you have what we call the non-small cell variant, and they can be very aggressive, and one of the things that determines how you're going to do is the extent of disease. And so what we have to do next is to do several more what we call radiographic procedures as part of a staging. And you may have come across...
X-rays? X-ray?
Yep.
Okay.
You may have had friends that have had cancers, and they may have said, well, I have stage 2, I have stage 4. That's what we're going to do next.
Okay.
The staging determines not only how well you do, but what kind of therapy that we go ahead and administer. I can tell you that at a minimum, based on what we know now, that you will need chemotherapy and you may need radiation therapy. That being said, I'd like you to let me know if you have any friends, family members that have already gone through something like this, and what kind of things did you see and what kind of fears that may have brought out?
That's what was so surprising, is that there really not much of a... Well, actually, I had a great uncle, if I remember correctly, who had cancer, and they did something called cobalt treatments back then.
Right.
And
that's a type of radiation.
Right. That's the only person I can think of.
I had a friend in high school, it was like back in the 80s, and her mom had breast cancer. And I remember she was so sick every time she would have the chemotherapy, and she lost all her hair and she lost a lot of weight. But she did live, and she didn't have a high chance of survival, but she ended up living 20 more years, which was, obviously a blessing. But I remember it was really rough for her back in the 80s.
Right. So one of the things that allows me to help decide on what kind of treatment to do is to assess what we call your performance status. Now, in these days, I know a lot of people will go on the internet and start looking things up. You may come across that phrase. All that phrase means is your ability to function and to do the things that you like to do. So tell me what that's like for you. What are you able to do? What things do you like to do? Have you been inhibited in any way recently in trying to do some of those things?
Oh, I'm a I'm a golf addict. Like to play golf. I think what got my attention was I couldn't play 18 holes anymore. I got breathless after the first 9 holes, and but it's still a passion of mine. I like to travel. Mom and I like to travel a lot, and sometimes we'll meet Carol and Kate somewhere and have a vacation together, and so I'd like to be able to do that. We don't go to church every Sunday, but we're pretty. We go on special days, and so being able to, and we have a lot of our friends we know from church, so it's we're pretty social people. Yeah.
So I do want to tell you that even though we do not know how extensive your disease is right now, many patients with your kind of disease do not survive. The length of survival, again, depends upon the stage, which we're going to try to find out between now and our next visit. How does that make you feel?
Devastated.
I'm really scared right now.
That's very natural. And that's why I asked about what you like to do. And the travel that came up, I know that's very important to you. Sometimes the treatments that we give are on certain schedules. But we can modify those schedules to allow you to do the things that you like to do.
Well, I want to live as long as possible. It's reasonably possible, with the quality of life that I can enjoy. So yeah, let's. I still want to keep active. So, but by the same token, I don't want to. If we're going to do this, I want to get started tomorrow. Yeah.
So what I'm hearing is that quality of life is very, very important to you.
Right.
So our goal should be to treat you and try to prolong survival as long as we can, but not at the expense of a significant impairment in your quality of life.
Right.
So right now, what I'd like to do is I'm going to order a CAT scan of your brain. Lung cancers like to go to the brain. I'm going to order a bone scan because they like to go to the bone. And then I'm going to order a PET scan. These are 3 different kinds of tests to see if it's gone anywhere else in your body. We can get all these done this week, and then I'm going to see you back next week. Do you have any other questions now before?
I'm sure I'll think of all kinds of questions now, or later, but I can't. I'm just overwhelmed right now, Doc.
And it's okay to feel that way. One of the things I like to tell people is to get a notebook and write things down. You'd be surprised. You'll wake up in the middle of the night and have something come in and just write it down.
Yeah, I have one in my drawer, in fact.
And there's no such thing as a stupid question. Okay?
Okay.
And are you going to bring other family members with you next time, or is this going to be Carol with you?
We probably should bring Mom, don't you think?
So what I want to bring out is sometimes when we go to the physician office or have a healthcare worker in front of us, they ask us questions, and you're thinking, why in the world are you asking me that question? And we're really assessing, and that's what Dr. Allerton did. He was assessing and he was exploring is what he was doing. So he was asking those exploring questions because he needed to know what was important to John. And that helps him then create treatment options or to provide treatment options for that patient that's before him. But he's got to explore a little bit. And sometimes we ask the same question twice and maybe a different way because sometimes you might answer that question a little bit differently for us. And we need some information. So just to kind of understand a little bit how healthcare workers what our minds are. We're assessing, we're exploring a lot. You may call it probing, but we really are trying to respect your choices. And the only way we can respect those is if we know them. So just to kind of give you a little bit of idea of how our minds are thinking as we're going through this. And then he explored the fact that, what Carol's role was here today as well. Not quite sure what that looked like when they first came in. So that way he would know then how to communicate and if there are other family members that we need to be, again, inclusive and not exclusive, because we want to make sure that we include them in this conversation. So as the disease, because that's the next scenario, because as the disease progresses, then the conversations continue on. And the conversations get a little bit deeper because the quality of life that John has right now may not be as good as what he would like, but yet it may be tolerable because that's his new norm. Does that make sense? Okay. All right, so questions from this scenario. Okay. All right, we're going to move on to the next scenario.
They're grieving.
They're grieving?
I was thinking either that or Dr. Allerton nailed it.
Yeah, he did. He nailed it. But we're going to move now though to the disease is progressing, so it's become more chronic, and we're getting to the point now to where we're going to talk about more end of life health care and wishes. What are those wishes? So that way he's going to assess, he's going to explore, so he's asking questions. So if you haven't thought about these questions before you've come in, these are hard questions to answer. Okay, go ahead.
We don't have a person to represent
I know.
my wife. I just thought about that.
Okay,
but, yeah, we'll pretend she's here.
John, nice to meet you again.
Dr. Allerton.
Carol.
Dr. Allerton.
Okay. So after our visit last time, I know we talked about a lot, and you underwent your staging. Do you have any questions regarding the things that we discussed last time before I get into the results of your staging?
No, I hope you have some decent news, but I know, you said non-small cell is the worst kind, so obviously my mind's been racing and imagining the worst. So
have you had a chance to look anything up?
I've spent a lot of time on the internet.
And what did you find?
It wasn't as encouraging as I was hoping at all. It was really kind of a little frightening. And
did you share some of that with your dad?
Yeah, some of it. I mean,
yeah, she showed me. I'm pretty adept on the internet, so I did some checking myself, but don't have as much. Funny thing, being retired, I have less time than I did when I was working, but I did some exploring on the internet.
Well, let's go over your results. First, the bone scan. Your tumor has gone to your spine in a couple areas.
So that explains that back pain I've been having.
I think he thought it was from golf.
So you have one lesion that is between your shoulder blades and another one a little bit lower, right around your lumbar area. They don't appear to be near your spinal cord at this point in time, but these are lesions that we normally want to radiate, the cobalt that you had mentioned, before they progress to the point where they could be causing more significant pain or pressing on the nerves.
Yeah, the pain's pretty bad at times, and I certainly don't want it to get any worse.
What have you been taking for the pain?
What's that drug that has Tylenol on it, but it's more powerful than Tylenol?
Norco, Lortab?
Lortab, that's right. Yeah, I've been taking Lortab.
There's some things that I can do to help with that as well. I'll talk to you about how to manage your pain regimen. Let's move on to the MRI of the brain. Even though you have no neurologic symptoms, you have at least 3 lesions that they can see. That is not uncommon for people with lung cancer. Many times they are completely asymptomatic. We scan them for a reason because it's so common to find these things. And again, the goal here is to treat them before they become a problem, before you develop seizures, trouble with your vision, weakness in your arms and legs, sometimes having stroke-like symptoms. So this is another area where we like to use radiation. The last thing...
Can you do both at the same time?
You can, absolutely.
Okay.
The last thing is the PET scan. So,
sorry, you're right.
Yeah.
Not only has this gone to your bones and to your brain, but there are numerous nodules in your liver. Have you had any trouble eating recently, or have you been losing weight unexpectedly?
Yeah, I've lost about 20 pounds in the past month. That would probably explain it, right, Doc?
Yes, it would. Getting any sweats at night?
Yeah, as a matter of fact, I, a couple nights ago, woke up in a cold sweat and couldn't get back to sleep.
Right, that's from the liver lesions. So by definition, you have stage 4 lung cancer. And
there ain't no stage 5.
I just can't believe this.
I know this is very hard. And what I'm going to tell you next is also very difficult. This is incurable. We do not have the ability to cure people with this advanced kind of stage 4 disease.
So even that radiation isn't...
Right, so the radiation will control the lesions on the spine.
Okay.
It will control the lesions in the brain. It may even eliminate those lesions for a while.
So it can maybe buy some time, deal with the pain, but it's not going to cure me.
Right. The way I like to describe it is the radiation is like spot welding. It will take care of the lesions that we direct it towards. The chemotherapy that we mentioned last visit, that goes throughout your entire body. It treats cancer wherever it is. That's what we call systemic therapy.
And it makes you sick as a dog, too, Doc.
Well, I remember what Carol said the last time, that she knew people that had breast cancer and they lost their hair and everything. Not all chemotherapy is the same for every disease, and not all patients will react to the same type of chemotherapy compared to somebody else that may have gotten the same exact thing.
What if I don't have either of that stuff?
If you decide that you don't want any radiation to control your pain, because the radiation won't necessarily prolong your survival except to the brain, but to your spine it won't. If you decide you don't want that and you do not want chemotherapy, your life expectancy is about 2 to 3 months, even though you're feeling so well at this time. If we treat you, most people with your advanced stage don't live past 2 years. I could probably suggest, because you're in such great shape otherwise, that you could get out to a year, but that would be stretching it.
With the treatment?
With the treatment.
What's that year going to look like for him?
Well, that's what we need to talk about today. So there are various kinds of chemotherapy regimens that I can give you that are not very toxic but have been shown to work very well. And in general, I'll tell you it goes like this.
I don't even go there. I don't want chemo.
Okay.
I think we can try. What do you think would be the most bang for the buck?
Okay, so
treating
quality of life issues right now, and that's pain control.
But then I think that we should hear about the chemo because he says it's not as toxic.
No, I don't want chemo.
A lot of times we do not do chemo and radiation at the same time because we can't max each one out like we would like to. I think because of the lesions on your back and in your brain, because they have such potential to cause really quick, unwanted issues with you, that we need to do that. That will make you fatigued.
So he could still do the chemo later if you changed his mind?
If you change your mind.
Okay.
And we have lots of time to discuss that. Now, I understand from the first visit that, Carol, you are the healthcare representative.
Mm-hmm.
Do you have a living will?
Yes.
Okay.
And it states, I believe I chose the second option with regard to artificial feeding. I don't want feeding tube if it's just prolonging the inevitable.
So what Indiana has now is a form called the Indiana Post. It's physician orders for scope of therapy. It is similar to a living will, but it carries more weight in that it is a doctor's order. So it goes through whether or not you want aggressive resuscitation, and there's modifications on that, whether or not you want artificial feeding, antibiotics, IV fluids. It spells it all out in succession.
Sounds kind of like a DNR order, but more goes into more depth.
Right. So I'm going to go through this briefly today, but I'm not going to have you fill it out today. I think with everything that we've gone through today, you really need to go home and think about this and talk it over with your family. Now, you may have seen on TV.
Mom's going to be devastated.
I know.
CPR. Tell me what you know about CPR.
Well, I know that it happens when you stop breathing and your heart stops, and they, do the paddles and do the chest thing, right, and stick a tube down your throat. And I've seen it all on TV.
Right. So let me tell you that what's on TV does not happen in real life. In patients like yourself who have advanced stage cancer, the chances of surviving an event that requires CPR is only about 2%. That being said,
2%. Wow.
Even if you were to survive, you're still coming back to
I
the
still have the lung cancer.
You still have lung cancer that is otherwise incurable. Yeah. So that's something that you really need to think about.
I can't believe that it's just so low, because it looks like,
That's right. It's very much of an in-service what they do on TV.
I always thought that it was, that's what you did, and
In fact, they don't even show you the way it's really done. And I like to tell people this just because it is a little graphic, and I'm not exaggerating at all. But you have to press the chest down at least 2 inches in order to get enough pressure to make the heart pump. In somebody that has bone disease, or maybe just elderly and frail, and they have bad osteoporosis, that results in multiple fractures of the chest. You cannot do chest
or
compressions.
metastatic lung cancer.
Right. You cannot do chest compressions without breaking somebody's ribs. I want to give you something to read about CPR and its effectiveness.
we're definitely going to have to share this with our family, because I know that if we go home, and I feel like they're not even, I can't even hardly believe this, and I'm sure they're going to have a hard time. So, yeah.
Now, you mentioned being on a ventilator. Most people with cancer, if they go on a ventilator, don't come off the ventilator.
No, don't want that.
They may even require a tracheostomy. So I want to give you something about the ventilator.
Okay.
Many people have a hard time thinking about eating and drinking towards the end of life. You know the commercials you see on TV about the starving kids in Africa?
Yeah.
Those people do have discomfort from not eating and drinking. The way the body is made, however, when somebody is dying from advanced cancer,
they don't have that same physiology, and therefore it's been well studied, they don't have that same sensation of need and suffering. We do know from lots of studies that artificial tube feeding, TPN when it's given by IV, artificial hydration actually causes more harm than good in people that are dying of any kind of end-stage disease, whether it's cancer, people on dialysis, etc. So that's something to think about as well, and here's some information on that. Now, the post form, I'm going to give you to take home.
Okay.
The first part of the post form is very simple. It says you either want resuscitation or you don't. If you do want some type of resuscitation, then it's subdivided in Part B. This is where you have various options, how aggressive you want to be or not. And they give you some different things here to think about under each category. And I'm not going to go through all of that now, but I want you really to think about this when you go home. The next section is whether or not you want antibiotics or not. If patients do not succumb to the cancer themselves, the second most common thing they pass away from is an uncontrolled infection. Sometimes antibiotics can actually be used to help someone relieve the discomfort from a particular infection, but many times they don't. It's just prolonging the inevitable. And we can talk about that in more detail as well. But there's a section here, antibiotics for comfort or no antibiotics at all. We talked about artificial nutrition. That's the next section, either yes or no. But they threw in another category with this. Some people choose to give it a trial.
Okay.
You can say, yeah, I would like you to feed me for a couple of weeks, and if things aren't turning around, I don't want to be fed anymore. That's the purpose of that little subdivision.
I would imagine it kind of depends on kind of what events in the future you're kind of looking forward to and want to live for.
Absolutely.
And, I can see how that might be helpful.
The next part of the form is for you as the healthcare representative. This is where you sign your name.
Okay.
The last part of the form is mine.
Okay.
After we have discussed this and you have gone through all of this, which we can do the next visit or so, then I sign it and it becomes an order. And then I keep a copy and you keep a copy. I like to tell people that the EMS will look for things in the refrigerator, in the freezer. So you can keep this in the freezer.
That's weird.
Okay, that's
Is
where
it
we're
because
trying to keep
they're hungry?
It's fireproof. That's why, I bet.
That's why.
That makes sense.
Now,
Okay.
the last thing I want to mention before we wrap it up today is that even though this is an incurable
This has
disease,
been quite enough already, sir.
we know that by treatment we can improve your symptoms. We also know by many studies that we can actually prolong your life. I know quality is important. I know there's a lot of things that you like to do. So even if you were to agree to some type of chemotherapy and say we went through it for a while and you had planned a vacation, we could stop the chemo, let you go on vacation, and then you can come back and we can resume. I'll just tell you the story about a patient that I had very recently. It was a mom in her 40s, and she had several daughters, lots of grandkids, and she was undergoing therapy, but it was getting too tough for her. One of the things on her bucket list is she wanted to go to Florida. And so what we did is we gave her a break, knowing that during that break, things were going to progress. She decided to rally her family. They put her in a car and they drove to Florida. She had a great time during that week. When she came back, she and the family had been talking a lot in Florida, and they decided that this was it. No more therapy.
and she went home. She went home with hospice, and she passed away with her family at her bedside. So there's not one right way to do this. Things can be modified over time.
Yeah. Well, I don't want to linger over these decisions too much. When's the next time I can see you? I mean, relatively soon.
I'd like to give people at least several days to think this over,
Yeah.
maybe a week.
I think, and we need to talk to Mom and to Kate too.
Yeah.
And in the meantime, I will set you up with the radiation doctor because that needs to start right away.
Oh, yeah.
And again, that's really not going to make you sick. The biggest thing there is going to be fatigue.
Yeah. Okay. Yeah. And that each day the pain in my back seems to be getting worse and worse. So I can't imagine.
Yeah.
I want to control that as much as possible.
And the radiation will help to control that almost within the first 3 to 4 days. And I'll help you with your pain medication regimen as well.
Okay. Okay, Doc. Tough news, but we'll
I just
rally.
want you to know that I'll be here for you. We have a whole team here in our staff, and we're going to see you through and be here with you.
Thanks, Doc.
Thank you so much.
Carol.
Great. Thanks.
See you next week.
Good job. That was a difficult conversation. And I know it's difficult as a healthcare worker to give that to have that conversation. These guys have those conversations on a daily basis. So you can tell that they're very skilled at having those conversations. Again, assessing, exploring, very patient-centered, and that's the way it should be. He also gave great explanation about the disease process. You as the patient and the family have the right to have that information and to understand it. And when I say understand it, I know it can be difficult because we have a tendency as healthcare workers to say words that, and it's okay to say, I didn't understand what you just said. What was that word again? You have the right to understand what that is. You have the right to acknowledge what your wishes are, whether that's verbally, whether that's written. One thing I do want to say, I know we've talked a lot about the documents. And tonight the importance is the conversation. The conversation is the most important. And when I say that is because those around you that are whoever's going to make that decisions for you when you can no longer speak, they need to know what your wishes are so they can be respected. Today, this is, things happen for a reason. We had a person come into the ED today, and the elderly gentleman he couldn't breathe on his own, and he did not have a heart rate. And his elderly wife and granddaughter were with him. And went out there and talked with her and told her the situation. And she said, he told me that he did not want one of those tubes in him. He does not want to be on the ventilator, and he does not want a feeding tube. He told her that. There was no written form. But the verbal communication is just as legal and just as binding. So I went in the ED, or I went to the room. I told the ED emergency physician, I said, this was just told to me by his wife, and she is the healthcare representative. She didn't have any paperwork with her. We
call
took
that
the verbal.
a verbal advance directive, and it's like Sonia said, it's just as legal as a written document.
Yeah. So that happened today. So just, you never know when that's going to happen. This gentleman didn't know that today was his day. I don't know if tomorrow's my day or the next day's my day. But again, having those conversations are vitally important. They're difficult. And I make mine, I use humor when I have conversations like this because it can be hard. It can be difficult. I mean, tonight's been, I don't want you to think tonight's a downer. Tonight's, it's a means of giving you the power to have a voice when you no longer have a voice. And I find, and again, going back to it is a gift to your family member. So I'm going to open it up to questions at this point.
I have here a sheet of paper that says appointment of healthcare representative, but then on the post form on the back, declaration of healthcare representative. Suppose I change this sheet of paper to another daughter, but forget to change this one.
This one, your Indiana Post, what he's talking about is, you in your packet, you have a Indiana Post, and on the back it has a healthcare rep. So this one piece of paper could be your entire wishes on it. The Indiana Post, the criteria for an Indiana Post is if the physician asks the question, would I be surprised if this patient passed in the next 12 months? And the answer is no, I wouldn't be surprised if they passed. Then you qualify for an Indiana Post. The other is frailty. So but going back to your question, so I just need to make sure, if you're healthy right now, you want your healthcare rep and a living will. You want those two forms.
If you already have a healthcare representative chosen, you don't have to fill out that section.
Right. You don't have to. Right. But it can be one piece of paper or it can be that piece of paper. And then say if you have both but you presented to us, we would take the one that was dated last. Okay, so the newest form is the one we would take.
There was no mention of cost for any of the procedures. Isn't that a legitimate thing to ask for? How much does it cost?
Cost of this or cost of procedure? Yes. Yes. Yes, and we can give you estimates of what those costs would be. Yes, those charges. And each person has different types of insurance with different things, so we have to take that into consideration when we do that.
One of the things that's good about that question is most offices now will have someone that is able to help people afford to get some of these things that they normally could not get. So in our office, not only is Carol a social worker, but as a patient navigator, she has access to various funds that are available, access to pharmaceutical companies to get things for free. So yes, there is a cost, and you got to think about the cost, but there's ways to help get around that too. So cost shouldn't be, in my opinion, should not be the primary determinant of whether or not you elect the therapy or not.
We need to explore the avenues and the resources.
Recently that was resistant to getting treatment based on cost. He was so afraid that he was going to leave his wife basically bankrupt. But we were able to get the medications through a pharmaceutical assistance, and he needed to be on an oral chemotherapy, and those are very expensive. And he, at this point, he was could barely walk, and he now can walk without a cane because he had so much pain from the cancer being in his bones, but it's really kind of managed. And so he and his wife actually took a vacation last week. So it's important to bring up your concerns about cost because sometimes there are ways to work it, or there can be alternative treatments or alternative drugs that can be used. So absolutely, definitely always bring up, I'm concerned about that because it's an important part of your health.
I can tell you that doctors don't know most of this information. We're not told that, and it's considered unethical for us to know the exact cost of a lot of these things, because then we, as the docs, can pick and choose, based on cost for the benefit not of you, but of the pharmaceutical companies and things like that. So we kind of have a general idea of how much things cost, but if I'm honest to you, I can't tell you how much cost of therapy is. We have to send you to someone like Carol or somebody in the business department to kind of plan that out for you.
Yep. Good questions. Great questions. Got one over here. Give me just a second.
I probably shouldn't comment on this, but isn't it kind of unethical to talk about cost? And the reason I bring that up is taxpayers pour billions into National Institutes of Health, for example, and other, support of private companies for research on drugs and so forth. So the idea that somehow cost should be a determinant should be considered when the fact that almost every citizen in the United States pays significant amount of taxes to develop medical cures, and that really should be available to everybody.
Well, I may be a type of person who's, say, socially conscious, and so I may say, well, I'm dying, basically. I think it's a better utilization of healthcare resources to let that money go to somebody who needs it more than I do, and I can make a decision based on money for that reason, if I wanted to.
So
Sure,
that's going back
sure
to
I
each
could.
person. As we were earlier, we were trying to understand, explore, and assess. That's going back to what that person wants.
Right.
One person may want that information, and another person, I don't even want to know.
Patients, because we do work in oncology and people know how expensive a lot of oncology treatments are, people do bring up, I'm really worried that this is going to cost, how much is this going to cost me? Is it going to affect my family? And again, that's where my role is, to try and help make sure that everybody has access to the care that they need without bankrupting them.
Right.
So that's part of my role, is to help make sure people can get insurance if they don't have insurance, that they can get the medicines they need, so that cost doesn't become a factor for them.
And the number one cause of personal bankruptcy is health care costs.
Yeah.
And we have people that walk in the office every day who are uninsured, and they've been diagnosed with we've got somebody that's 30 years old with a malignant melanoma that's gone to the brain, and his chemotherapy treatment is $250,000 per treatment, and he'll have 4. But we jumped in and got insurance for him. We've gotten things taken care of. We've worked with the pharmaceutical companies, and he's getting all that. We also assisted him in getting signed up to get disability, because he's not able to work. He's not able to support his family right now. So we really are working to try and take the cost of, that equation out, so that people are making decisions based upon their values and what's important to them, and that's not kind of pulling them down.
Yeah. No, and then, so as a family member, so I can use this as a personal experience, is cost is, my husband was diagnosed with cancer around 2001, and I was, and we had 2 small boys, and his big thing was, financially, what's this going to cost? I mean, those were his questions. And I said, you know what? Don't you worry about that. I'll be the bookkeeper. Just don't, your goal is to get treated and to get better. That is your goal. And then, so then I took on that responsibility as the financial person. So I was the one in the financial office. I was the one asking the questions, and then, and paying the deductibles or the co-pays or whatever that was. And even to this day, and luckily he's still alive, everything's all good, but he still needs to go back for his yearly, and I still pay the bills, and he doesn't want to know, because he feels like he's a financial burden on the family because of those expenses. So I understand, that question's a great question, because people do feel in the household that they are a financial burden on everyone else. So that's definitely a legitimate question.
Yeah.
Having read the book Knocking on Heaven's Door, I would be very skeptical if my heart surgeon said I needed a pacemaker. What doctor do you talk to?
I don't know. Which doctor do you talk to? I guess you need to have the conversation to tell him what your values, your goals, and your beliefs are, and what you want, and then you can make that and making that decision with your physician. We're not a heart doctor, and I don't know if that answered your question. It's based upon your goals.
I don't trust him.
Okay. Oh, well then fine. Go with another doctor. Yeah. If you don't trust your physician. Yes, definitely. Definitely. Yeah. Okay, other questions? And then we're going to wrap it up. How's that? Does that work?
Well, I know when John and Carol came in for their first meeting with you, Carol was identified as the health person. And I was wondering, if there was not someone there who had been identified that way, would your conversation have started differently in that, say, maybe his wife was with him, or Kate in from California, who would you begin with talking with them about the need for a health directive? Would that be a part of your conversation?
Yes. So anybody that walks into my office with a disease that I know has the potential to kill them at some point. It may not be the first visit, but it's usually around the first couple of visits that I will bring up the fact that they should start getting their affairs in order. If somebody presents to me the first time, though, with metastatic disease that, again, I know is incurable, that first visit I usually bring up, the healthcare rep and start talking about the will, getting an idea for what they want to do with the rest of their time, that sort of stuff. I also want you guys to know that what I did here was really condensed. This doesn't happen in 2 visits. I mean, there was a lot of information. A couple times he kind of put his head down. I think he was trying to give me a signal that this is enough. But, I kind of wanted to go through what the things are that I have to go through.
He was relentless.
But, this is a couple of visits then. It's incredibly rare that I do this on 1 or 2 visits. It's only times, and I've had a few even this year, where I see somebody on the first visit that is in near extremis, and I kind of have to push things pretty quickly. But usually it's through, getting information from the patient and their family members, talking a little bit about stuff, letting them process it, bringing them back, doing a little bit more. I never, ever do the post on the first visit, ever. It's something that I think is too personal, and it has a lot of implications, and you really need to think about it. Today I did one in Bedford, and the family was given the post a week ago. And I kind of gave them a lot of background information to think about. I gave them a handout. There's even a handout that we have about how to fill out the post. It's a couple of page handout. And I gave that to the patient and the family. And told them if they had any questions, call me, call the nurse. But, we'll go over this again next week. And that next week was today. And they actually had it all filled out already. And they were all pretty happy with it. And I signed it.
Okay, good. All righty. We're going to go ahead and close. You have the information about, again, in your packet, you've got the forms, you've got the landing page, you've got the telephone number to call. I know we're all open to help you in any way with assistance in completing those, having your conversation with your family. Maybe you don't want to open it up, but you need one of us to help facilitate. We also have other facilitators trained here in the organization as well as down in Bedford. We just did some training sessions down there as well. So thank you very much. Greatly appreciate the attention and the time that you've given us this evening. I'm going to let Nancy close it.
Thank you. I think we should give a round of applause to our role players. They did a great job for us.
Yeah, I know. Yeah.
Yes. Thank you. Thank you. We appreciate they've shared a lot with us tonight of information and insight, and I think all of us are going away with a lot of thoughts about the things that we should do in the future. And I did, again, want to emphasize the forms that are in the back. If you didn't pick up a packet on the way in, please be sure you do that on the way out. Our 4th and final session in end-of-life concerns will be September 23rd, and at that session we'll be addressing the issue of caregivers for end-of-life, which I think is very, very important for us to think about that aspect of it also. Again, I'd like to thank all of you, and I'd like to thank the IU audiovisual people for recording this evening, and we hope that this is going to make its way to BCAT so that it will be available on public access television as well as on the intranet here at Bloomington Hospital. So thank you all for your attendance.